Given the subspecialty focus required of elite bladder cancer urologic oncologists, why are there no uro-oncology fellowships devoted specifically to bladder cancer? Why are there no subspecialty medical society, medical organizations specific to bladder cancer other than Beacon? I mean, what is your perspective on that? Either one of you can answer that question.
Yeah, well, I'll tell you, I'd be happy to take just to make a couple comments. Urologic oncology, it can be 1 or 2 years for a urologist. Obviously, or not obviously, medical oncologists tend to do general medical oncology, and then they subspecialize in a niche of genitourinary. And just to be fair, the pool of patients for specifically advanced bladder cancer or what typically is seen by urologic oncologists would not be something across the United States that would inundate every urologic oncologist. Now, at the same time, people tend to be drawn to certain areas, and they tend to have some folks tend to have more of a bladder cancer or a kidney cancer focus, but urologic oncology is a pretty small field to begin with, so that training is spread amongst about 3 or 4 disease states. I don't know if you have anything else to add to that, Mary.
No, that's a great answer, Steve. Thank you.
So in cardiac surgery and joint replacement orthopedic surgery, there are published data relating favorable outcomes, both morbidity and mortality, to both the surgeon and patient volume, the number of cases that the doctors are seeing a year. Is there similar data out there for cystectomy? What's the minimum number of cystectomies a year below which a patient should be concerned in selecting a surgery and a surgeon, or a hospital volume overall? I think, I know I always tell people you don't want to go to the doctor that says, oh, I read about that in the journal once. You want to know that you're going to an expert. So are there data out there that patients can find that help them understand a surgeon's experience in a particular area? Or is it something that the surgeon themselves need to provide? Should they provide it?
Yeah, that's a great question. So there is published literature to suggest that, and it really falls in line with the reference to orthopedic, but it's not unique to bladder or orthopedics. It's higher volume centers, higher volume surgeons tend to have better outcomes, but you have to be very cognizant what that means as well. That is not only the surgeon, but that's the aftercare, the familiarity. It's like anything in life. If you do it repetitive over time, you most likely do it better and better, and you learn the nuances of it. In terms of finding specifically the numbers, without published reports from those institutions, I don't know that you can specifically find them. So I think you got one of two options. One, you can search and see if that's reported. There's a lot of places that do publicly report their numbers, departments on department websites per se, or urology websites. They may, not so much pure private practice, but a lot of department websites will put out publications per year looking at their cases, their volume, their outcomes, etc. But then I think equally, that's equally viable is, I think if you ask that and you get a very delayed or uncertain response, then I think you can start to become clued into the fact that maybe that's not something they do all the time. So I would probably, if you don't have time to look that up, or you can't find the published data or on their website, then I would just pose that question in a very non-threatening and appropriate, respectful manner to the surgeon, and then you would have to judge their response from there.
No, Steve, I think that's a great answer. I mean, I tell folks all the time, if you have a question like that related to your surgeon's specific numbers and volumes and outcomes as it relates to certain things, with any urologic surgery that we do, patients have a right to ask that. And I think that Steve is right. If you get kind of a dodgeball answer or kind of hesitancy, then that might be a flag that that you may want to be getting a second opinion. But the vast majority of the surgeons who who I've worked with are very direct and straightforward with folks, because at the end of the day, it's the patient's life and it's the patient's body, and and we want everyone to feel comfortable with their treatment team.
I have a question from a patient who says, my urologist is always too busy to answer questions during tests. How can I get information from him, or it could be a her in some cases?
Wow, I think that's a very insightful question, and I would say the reality of it is that we're all providers are experiencing this increased patient volume and challenges in how they manage their day, especially in the clinic or in seeing patients. And so I can certainly appreciate that sense from some patients. I would say a couple things. Number one, I think you have to understand and appreciate that there is going to be a time limit to that appointment. And what I mean by that is if you take that approach, then you come in there focused and ready. And that gets to the prepared, i.e., you sit down and say to them, you understand that you may not get 19 questions answered that particular visit, but you need to prioritize the 3 you want and make sure you get those 3. So you have to help your physician or provider focus you on to you and the questions you want to answer. Number one. Number two is, I think if you do figure out the way they like to communicate, I think they're not. Most providers will tell you they're not as pressured in an email or a electronic communication setting. So if you say, hey, do you mind? I know your time's busy, and I know you have a lot going on, a lot of other patients to see. Do you mind if I follow up with you with a couple of questions? And then the third thing I would suggest is, hey, if you didn't get it the first time, call back up and say, hey, I would like to make another appointment. And you just, again, come in there with the 2 or 3 questions that you want. And again, be realistic, but also don't be unrealistic that you're going to get 75 questions. And I wish it wasn't always that case, but I think that is the reality. And I think you need to understand the playing field that you are on at the time. Mary, I don't know what comments you have on that.
No, I think that's great. I mean, it's really complicated, right? Because at the end of the day, we all wish that we could spend, an infinite amount of time with folks face to face, kind of addressing all the questions that we could. But prioritizing is really helpful. And just one more point to that is that, ask your nurses. So the clinic nurses or the nurse navigators, sometimes they're excellent conduits for filtering your questions to your physician or your NP or PA, but also a lot of times they can answer those questions. The more experienced they are, the more they become experts in the nuances of treating patients with bladder cancer. And if they can't answer the question, then they can, certainly kind of filter it to your provider.
Yeah, that's actually a really good point too. I would say I think some people or some patients feel like their questions aren't being answered because they're not getting them from the physician. But you got to realize in a team approach, for a lot of places, especially places that do a lot of this, your nurse practitioner, PA, your advanced care provider, your nurse may be able to answer that question in a very different way, and that satisfies your needs, and/or answer the 7 of the 10 questions you have, and then help you get the other 3. The answers to the other 3 questions. So maybe not so hyper focusing that on the physician, the patient, and feeling like they have to answer everything may help you kind of globally get to where you're trying to go.
Do you use IBM Watson to suggest a specific treatment for a patient with non-muscle invasive bladder cancer, along with or instead of BCG?
I'm assuming that's I'm assuming that's a slightly a humorous question but I'm not familiar with anything outside of IBM Watson outside of the commercial. So I guess the short answer would be no.
So how do you find out if genetic testing is available or necessary for grade 3 non-muscle invasive bladder cancer?
So again, I can take that. I'm a little uncertain of the exact question. The genetic testing in bladder cancer right now is still a progress in evolution. So I'm not sure if specifically what they're asking for in terms of that. I would need some more clarification and probably need to take that offline.
Okay, yeah, I think it was more, how do you find out if it's available or
Oh,
necessary?
available. I'm so sorry. It's currently not available in that space. There is no commercially available genetic test specifically for what they're talking about right at this time. There are a few genetic tests looking at different a couple different spaces, but the short answer right now, there's nothing in that space available.
Right. So I think for some patients, they might have a genetic test if they participate in a clinical trial because it's looking for those genetic markers. Am I right?
Yeah, correct. I mean, I think that's the other way. That's the other way to infer that question or answer that question is you may have it as a companion to a trial, but it's a lot of this is exploratory and kind of using it in the confounds of the clinical trial or in the boundaries of the clinical trial to understand um, different goals of the trial and different tissue-based markers, but specifically to use it ubiquitously. Hey, I show up, I've got a grade 3 bladder cancer, and I want to use a genetic test to help me better predict, like we're doing in prostate cancer, they're doing in breast cancer. Right now, that's not prime time ready.
And then I think this is a great question to kind of close on because we know that the bulk of bladder cancer patients are not seen in large academic institutions as you two are practicing in. So should someone with bladder cancer look for a urologist who is a bladder cancer specialist, or will a general urologist be acceptable?
Yeah, so honestly, we have really wonderful kind of partnerships with a lot of our community urology type practices close to us around the state and in other states. And I think that's the general feeling at most academic medical centers. We get a lot of our referrals come in from community urologists who maybe saw patients first who had blood in their urine and then did their cystoscopy and then did their tumor resection and then refer to us for discussion of treatment options. Because we are, a bladder cancer center of excellence and have many specialists who are experts. So sometimes the way that it works is that we will, kind of resume care of patients. And once we're kind of completed their active treatment with us, then they follow up locally with their local urologist. So it's kind of like a tag team approach. Sometimes patients will come to us from local urology, to get a second opinion about, should I do BCG? And we, check it off and say, yes, we would do this too. And then they go back and get their treatment there. Sometimes they go back, and do treatment with local medical oncologists. So I think it really is what's really important between kind of community urology providers, community medical oncologists, and academic medical centers is collaboration and open lines of communication, between the providers at each institution and also the patients, so they know kind of who is in charge of what aspect of their care. I don't know if Steve, if you want to kind of elaborate on that.
Yeah, I mean, it's a tough question. This is probably the question I get more than any question is, does everyone with bladder cancer need to see a urologic oncologist or go to a center of excellence? I think the short answer is no. I think the long boy, it would take an hour to go through this. But I would say a couple things. Number one is you should not be afraid to seek a second opinion. And sometimes all you're doing in the second opinion is just confirming that what you're getting done locally is okay and kind of getting that level of comfort. And then, and I think too, you should pose that question to your urologist. And I guess the other just logical thing I would say, listen, if you're in a really, really small area with one urologist, two urologists, and you've got a disease that is not that they may not see all the time, then it may be, again, worthwhile if you have the means to go somewhere else and just to make sure that just to dot the I's and cross the T's, and also at the same time engage with that second opinion that, hey, can I not get this locally? Can we not do this locally, or come back at certain periods across the course of your treatment for kind of a reaffirmation that everything's going the right way. But at the same time, there's a lot of good general urologists out there, and they really know what they're doing in the space. And I have a lot of confidence in our field that they do make the right decisions, and that if they feel like they need for you to go to somewhere else for a second opinion, then hopefully they'll be equally engaging you in that discussion.
Well, this has been an excellent program. Thank you so much, Dr. Stephen Riggs and Nurse Mary Dunn, for really sharing a lot of really good insight. You know, we know that patients have questions, and I think you both made it really apparent that it's important that patients step up and ask those questions and not just say, well, gee, I don't understand what's going on with my treatment. So thank you for doing that. I think that's an important step. To thank our sponsors, Genentech, EMD Serrano, Pfizer, AstraZeneca, and Merck for making the patient webinar series possible. Thank you for joining us.